Dylan, thank you for joining us today. Should I treat this more like an acute? Well, okay, so let's talk about how we would manage this in acute, and then we'll talk about how, well, we'll actually demonstrate how to perform treatment for somebody who's experiencing the chronic stages of healing. So in the acute stage, we know that there's not much that we're gonna do to try and make gains in their presentation because they're still healing. All right, so we want to maintain things as best as we can, decrease their discomfort and their pain, and try and address any compensatory structures that may be holding. So basically, acute stage, work on just trying to bring their shoulders back, get everything to relax, and try and just get all of the hyper over-firing structures to just chill out a little bit. So in terms of acute, it won't do us much good to demonstrate a lot of acute treatment to you because there's not much we can do, right? So we are going to be demonstrating mostly in the chronic stage of healing. Okay, which means Neil's probably going to be complaining about, even though it's there's instability, there will still be a development of restrictions that have taken place at this point. So end range is going to be a little bit stiff for some of the joints. All right, so we're going to try and increase our range of motion. We're going to increase mobility to the hypomobile segments, as well as decrease restriction in the areas that are experiencing restriction. Okay, so Neil, thank you for joining us. After we've done our thorough Hopner's assessment with all of our special testing and all that good stuff, we have determined that you have cervical instability, unfortunately. So what's going to happen is we're going to go ahead and perform treatment to help address the dysfunctions you're experiencing. For this treatment, I will be working on the upper portion of your back and shoulders as well as into your neck. And then we're going to have you turn facing upwards, and I'm going to do some work into the upper portion of your chest, a little bit into your shoulders, and around your neck, head, and possibly around your jaw as well too. So the purpose of this treatment is to hopefully decrease some of the hypertonicity you're experiencing, to try and increase some motion of your neck because you're a little bit restricted, and try and increase some strength in those tissues as well too to better stabilize. There is a chance we might possibly provoke some discomfort during the treatment, and you may experience some discomfort even after treatment for a little bit. If you experience discomfort at any time, please let me know. We can modify things accordingly. But hopefully we'll be able to give you some relief of some of those symptoms with your dysfunction. Yeah, so told you where we were going to treat. I'm going to go wash my hands and grab you a set of linens. And I'm going to come back with those linens, and then I'll get you to lay on your tummy facing downwards after you've undressed the upper half of your body. And if you could remove your necklace as well too, that'd be great, please. Do we have an extra set of linens here?
You never know.
I mean, like, if somebody left their linens here, then it's free for all. Okay, cool, we got linens.
There's even more over there.
Great, we got lots of linens.
I smell good, so.
Okay, yeah, that's the big thing.
Don't know who used it last.
Right? Okay, so the purposes of OPs, you would say, normally I would start with my patient face down to work on the compensatory structures to start, but unfortunately, due to time, I'm going to work directly on the neck only to demonstrate my skills related to treatment of the neck.
There you go, sir.
You have no shoulder pillows? Oh, I'm going to steal this from room 309. It's okay, if I get at least one set of shoulder pillows just for the demo, I can run and steal some shoulder pillows from you guys.
What's the other side?
On that side?
Yeah.
Yeah, can somebody track me down 2 shoulder pillows of decent size, please? My TA is now in a vulnerable position, so he can't.
What do you want?
Shoulder pillows!
Oh.
They're gone? All right, does anybody have a set of linens that is folded relatively the same? Because that works as well too. All right, Neil, we're going to be working on a pain scale of 1 to 5 to communicate the amount of pressure that I'm using and to determine your comfort level. Did you want me to go ahead and review that pain scale with you? Please say no.
No.
Okay.
I'm good.
Thanks.
It happens.
Appreciate it. Thank you. Thank you. All right. So I'm just going to start by placing some cushions under your shoulders, okay? Good. Actually, he really needs shoulder pillows. Do we have another set of linens? Because, yeah, I would actually bring his shoulders up quite a bit higher. All right, so first things first, we're gonna get into this stuff when it comes to hyperkyphosis, but a lot of the times when people lay facing downwards, their shoulders drop forward. Sure, are they folded?
Yep.
Good, thank you. And so the shoulder pillows are not only to create comfort, but they help to actually bring the shoulders back closer to that neutral position they should be in. Thank you. Now, usually I don't like using my patient as a table, but I am making an exception right now. There we go. So when we get into the T-spine stuff, I will be going more into explanation about why I'm doing what I'm doing, all of this good stuff. But this is not our primary focus for today's class. Good. That already looks so much better. Do you guys see how before the pillows it was like, whoa, right? Couldn't even see shoulder blades. But now you can actually see the edges of the shoulder blades. And I'm going to change the angle of this headpiece just a little bit, and you'll not be able to try that. So forward a little bit just to get that little bit of pressure off that back of the neck of his. All right, so when we're treating for the purposes of trying to address cervical instability, we know that the structures at the base of the neck are probably going to be trying to work a lot more than they should to maintain the integrity of that neck, right? Take a nice big breath in. And good, let your chest drop, and keep going, keep going, keep going. Good, take a big breath in. And drop in. Good, soften your neck. There you go. So these are the neurodynamic releases that we're going to be doing that lecture on after the midterms. Good, nice breath. And again, fall. Good, the upper portion, let it go. There you go, good job. Good, soften your jaw, let it fall, let it fall. Great job, well done. So essentially all you're seeing me do here is just some soft tissue work. As I've mentioned before, I think I mentioned to you guys before, I don't ever try and give you a recipe, you do this, and then you do this, and then you do this. I just demonstrate techniques that you can incorporate in your already existing treatment style. All right, because the idea is I want you to understand what's happening with these techniques and not just go step by step, I'm doing this because my teacher told me this is how I'm supposed to do it. Let's soften your chest. There you go, good job. And plus he kind of needs treatment. Good, drop your chest. Good. Keep going, keep going. Good. Under your arm. Perfect. Good job. All right, so we got a little bit of, actually quite a bit more laxity happening in his shoulders. Again, we're gonna get into that when it comes to T-spine stuff, but this side here is really, really stuck. Take a nice big breath. And out. Good, let it fall, let it fall. Keep going, keep going. Good, and from your chest. And very good, well done. Okay, so most of you guys will probably do a ton of your basic fascial techniques. You'll probably do some skin rolling, you'll probably do some Swedish techniques, you'll probably do some cross hand. Ideally, PNF would be a great addition to your repertoire sooner rather than later. An example of that would be kneel in. I'll get you to go ahead and try and clamp your underarm down towards your side. Perfect for 5, 4, 3, 2, 1. Let that go. Take a breath in. And let your chest fall. Good. Let your shoulder drift up to your ear if it wants to. Let it go. Let it go. Let it go. Good job. Let go of your chest. Perfect. Good job.
PNF or what?
Yeah, what were you?
What were you doing?
So when it comes to PNF stretching and PNF release, I was trying to target the structures in the area that I was working. So anything that will cause a contraction in those tissues will utilize the principle of reciprocal inhibition. Okay, so PNF stretching means technically I will have applied a stretch afterwards if you're applying a true PNF stretch, but you can still utilize the concept of reciprocal inhibition to get some tissues to just release further than they did before the contraction. So So that's essentially what I did there. Even though I did not actively stretch the fibers afterwards, we still recruited that reciprocal inhibition to cause the tissues to soften further than they were before he contracted.
So you just put a pressure and you
He
have
contracts into it, I resist, we hold for a little bit, and then when he relaxes, he breathes, and I can go further.
Okay.
Yeah. So it's like a PNF style release. We'll call it that then, because I didn't actually do the S in PNS. Right? Make sense? Yeah. Good question. Good question. All right. Nice big breath in and out. In a full hour treatment, you'll have the time to be able to go a little bit into the mid back, go a little bit into the low back, and actually address the entire chain of erectors, which would be ideal. I know we're working primarily on the neck, but all of these structures are involved, right? If you place your hand on somebody's low back and you tell them to lift their neck, you will feel their low back contract, right? So keep in mind that if you can, get as far down in the chain as you possibly can. Okay, so we spent about, let's say we spent like 10-15 minutes getting all these structures to feel nice and balanced from left to right. It's a little bit better. His right side is still quite stuck, but that's okay. After that, we're gonna get him turned over. Just a second, Neil, and I'll let you know when you're ready. So in order to turn somebody over, for the purposes of your education in this program and for the purposes of board exam, always remove all pillows. Always. Always. Right? For the purposes of dealing with postural dysfunctions in the upper chain, especially related to hyperkyphosis, I do not remove the shoulder supports until they are turned facing upwards. Reason being, is because as soon as I remove those shoulder supports, all of our hard work, right? So in an OP situation, if somebody's in your treatment room with a clipboard and watching you do stuff and giving you marks according to it, remove those structures, the pillows, right? But if nobody is marking you, do what you think is best according to your clinical judgment, right? There's that whole board exam versus real world application, right? So if I was being examined, I'm not gonna do that. We already talked about it. All right, so this is something I would like to see when it comes to turning your patient over, because I've seen a variety of things. I've seen people struggle. I've seen some really interesting happenings when it comes to turning an individual over. So as you know, pinning down the linens on one side, right? I'm gonna reach over, we are going to grab onto the other side of linens on the other side and cover as much of a span as you possibly can. Fold them over onto each other so that even if there is a pull apart, it won't actually create a gap for you guys to be able to see what's happening, all right? From here, what I personally like to do is the entire time that they are turning over, I look down towards their feet. Some people, they look up here, and some instructors actually say it's better that you do look up here so that you can acknowledge if there is an accidental exposure. But I am also of the opinion that when I'm like this, if there is accidental exposure, your patient will know, and giving them an opportunity to be able to correct it briefly can make them feel a little less embarrassed, right? So decide which school of thought makes most sense to you. All right, Neil, and I have secured the linens, both the top and bottom layer. Can I get you to please move yourself down on the table so your head's off the donut and then lay on your back? Good, and that way my face towards his feet. If there was any accidental exposure, he could deal with it. I haven't seen anything. Double check we're okay, Neil? Perfect. And he looks so cozy with his pillows by his head. Looks all tucked in, ready for bed. This is when I remove these, and then I get the pillow underneath his knees. Now normally I like having a nice large pillow underneath the knees. Why do we put a pillow underneath the knees? Is that the only reason why? Shakira, you know because you heard me say this before. Anybody else other than Shakira?
No, it's just a common fact.
Wasn't a common fact when I asked your class and nobody knew the answer.
I don't know, that's why I do it.
So the reason why we put the pillow, yes, to support the back of the knee, but there's a reflexive mechanism that causes us to stand upright without having to think about it. The posterior fascial chain of structures. If you're standing upright, the entire chain of structures in the posterior aspect is going to be tight. And that is the mechanism that keeps you upright so that you don't have to think about standing. Now, that means if you're laying on a table and your knees are completely flat with no pillow underneath the knees, guess what? You are engaging that posterior fascial chain to be pulled taut when it doesn't need to be. So you're putting a large pillow underneath the knees to actually disengage that tensile line, if that makes sense. Quinn, can you pass me that other pillow, please? Have you guys ever seen those little figures or whatever that's like on a little platform and it's held together with a string, and when you push the platform in, it like falls because the string is all loose after you push the platform in, and then you let go and then it's upright because of the tension through the string? That's exactly what's happening. Me putting these pillows underneath his knees is elevating that platform, putting slack into that string. Good. So I usually like the knees bent at least this much. How's that feel in the lower back of the room? Good. Right? So give it a try when you're treating your patient. Go ahead and try no pillow. Put a large pillow, get your patient to feel it, and literally pull the pillow out and see if they can feel the tightness that happens when you take that pillow out. All right, we're comfortable? Beautiful. All right, so he's now turned facing upwards. Am I gonna go directly into his neck right now?
No.
Probably not. Probably not. I would like to start predominantly in the upper portion of his back and the outer aspect of his shoulders. Can you get your hands higher up on your chest? Oh, sure, that works too. All right, so something that I'd like to point out first in terms of keeping the shoulders and the front girdle neutral and relaxed. Watch what happens when to my hand, I'll do this on this side so you guys can see as well too. When I take his hand and put it down to his side, watch what happens to his shoulder. You see it come forward, just by me putting his hand down. As soon as I lift his hand to put it on his chest, his shoulder is dropping back. All right, so when you have somebody's arm down at their side, it's actually bringing their shoulder protracted forward. So if you get them to rest their hands on their stomach, it allows the shoulder to rest and fall back closer to neutral.
Are you going to show us inside?
Yes, I was. Good, sorry. All right, so again, his hand on his chest, nice and neutral. I'm placing my hand here just so you guys can see the movement of his shoulder more clearly. When I take his hand and place it down by his side, his shoulder pops forward. As soon as I lift his hand to put it up on his stomach, his shoulder drops backwards. You see that? Cool. All right, so usually I will do a couple passes into the neck for assessment purposes only. I want to see what the tissues feel like. And it does feel like it's definitely more stuck on that right side. I got some questions for you, which I technically would have already done, but. And yeah, you definitely need some mobilizations done. That was a good class for you. Okay, so yeah, definitely lots of tightness happening in the lower aspect of his neck where his shoulders meet his neck. So normally I would spend a decent amount of time, probably about 5-10 minutes, trying to get the upper portion of his back and shoulders to relax as well too. Sorry. So grabbing into the upper traps, encouraging the front of his chest to let go. Take a nice big breath in and out. I'll just be super quick with this portion here and then we'll get into the neck component. So again, outer chest, outer shoulder, upper back, base of the neck, get those structures to let go. And soft. Good, drop. There you go. Good job. Good. All right, nice and briefly before I get into the neck, I will show you how to assess to see if you managed to work in the shoulders well enough to be able to move on to the neck. Neil, I'll get you to bring your arms up to the sky for me, please. Good. Thumbs towards me. Make sure the top draping is nice and secure. I'm going to get you to drop your arms outwards as far as you can. Can you see how much faster this side is moving compared to this other side? We'll go again. And then one more time, watch to see the difference in the speed that he has. And then in terms of restriction, there is more tautness at that end bounce than what's happening over here. So that is how I know that this side needs to be worked on. The other direction we want to assess, and this is the one that usually has more dysfunction for people.
Yeah, you can see.
You can see how much more tight and restricted it is on this side. Not because of end range, they kind of ended up at the same place, but how quickly this one came down and this one, it took longer to get down there, right? So that's showing us, even though they ended up at the same spot, there's restriction preventing the tissues from lengthening at the same speed as the other side. All right, so I like to use that as a little functional assessment to see if my chains are nice and loose. They're not, but we're moving good. Again, we're gonna go into that when it comes to T-spine stuff. Okay, once we worked into his shoulders a little bit, that's when we can go right into the neck stuff. The reason why we want to do the shoulders first is, as we mentioned, a bunch of the neck structures that move the neck are attached into the shoulders, upper back, and chest. Good, nice big breath in and out. This is probably going to be one of the most prominent components of what you're going to incorporate in treatment, which is your patient's deep breathing. So as you'll come to learn when we cover whiplash, most likely when there's instability, the hypermobile segments will be in the lower C-spine, and the hypomobile segments will be in the upper C-spine. So if we were to do joint mobilizations, are we going to do them to the hypermobile segments or the hypomobile segments? You guys are saying it so quietly, I don't know which one you said. Hypomobile segments, correct. All right, we haven't taught you guys any translations or anything like that yet, but just remember, you do not mobilize hypermobile segments. So first things first, working on decreasing restrictions, a nice pincer grasp, enveloping of the subocciput area, nice breath in and out. And you can apply an element of cervical traction. Now, I know you guys haven't gone through cervical traction yet. Essentially, I'm hooking into the base of the occiput and the mastoid process of the neck, and I'm keeping his neck in neutral to traction and distract the upper cervical spine. To target the mid-cervical spine, I'm going to add slight flexion to the neck. And in that slight flexion, that is when I'm going to apply a little traction that will target your mid-cervical spine. And then to target the lower cervical spine, we want to bring him up into even higher flexion with traction. So same idea as what we were talking about when it came to being able to feel the specific SPs move with a certain amount of flexion. This is where that actually comes into practical application. Okay, most people, you'd be totally fine with just tractioning with them neutral. It'll still feel great regardless. Okay, so when in doubt, neutral traction, totally fine. Let it go, let it go, let it go. Good. So you can do a gentle pressure release, engage the restriction with your thumb, sure, why not? You can get him to do slight activations. Okay, Neil, I'll get you to very gently try and turn your head towards the sink. Hold 5, 4, 3, 2, 1, relax, take a breath in, and melting away. Let it go, let it go, let it go, let it go. So lots of patient breathing, pressure release. You could use some PNF style releases if you would like. And then the other element that we are going to want to see during your OPs is activation of the structures that are supposed to be stabilizing. Yes, there is restriction in the soft tissue, but there is still weakness in the muscles that are supposed to be stabilizing. So, kneel in. I'll get you to go ahead and nice and gently, slowly lift your head up to look towards your feet. Ready? Go ahead and lift, 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 lift. Hold for 3, 2, 1. Back down. Very good. Any pain or discomfort with that one? No? Good. Okay. So this time, I'm going to be applying a gentle resistance, and I'm going to get you to just meet my resistance, and we're just going to hold in place for a few seconds. Okay? Ready? And go ahead and hold, push for 5, 4, 3, 2, 1. Relax. Good. If we want to test further into the range, that's possible as well too. Go ahead and maintain this here, new one. I'm going to gently apply pressure. Ready? For 3, 2, 1. Let go. Good. We can go even further into the range, right? And ready, hold here, new one. Ready for 5, 4, 3, 2, 1. Let go. Once he's gotten stronger with that, then we can apply a gentle resistance. Okay, new one, I'll get you to go ahead. When I say go, you're gonna go ahead and lift your head up to look at your toes. I'm gonna apply a gentle resistance, but I'm still gonna let you win. Okay? Ready? And go ahead and try and lift your head. Ready? Good. As best you can, as best you can. Not much of a resistance at all, right? And then back down. Very good. We're still okay with that one? Are you okay with doing that one more time? Perfect. Go ahead and push for 5, 4, 3, 2, 1. Relax. Very good. Now, once he's come back and he's like, yeah, I'm feeling a lot better, still need to increase my strength, what's the next level of resistance in the type of contraction we do?
Isotonic.
That was an isotonic concentric contraction that we just did. Eccentric, you got it. So Neil, what's going to happen is when I say so, we're going to get you to lift your head. I'm going to apply a gentle resistance to try and pull you back. I would like you to resist, but I would like you to let me win. Okay, so we're going to bring your head upwards. Good, go ahead and maintain that pressure from that hold right there. I'm going to apply a gentle pressure and just let me slowly win for 5, 4, 3, 2, 1, let go. So Neil Win doesn't have any cervical instability, but even then I had to put next to no pressure because gravity was doing enough work. All right, so keep that in mind. So there's going to be activations. We were working on addressing his postural compensations. We're working to reduce the restrictions he's experiencing in his neck. And then last things first. Then lastly, we can go ahead and challenge the individual joints. All right, likely hypermobilities in lower aspects. So I'm going to start in the upper segments with my joint mobilizations. You guys haven't learned this stuff yet, so I'm not going to go a whole lot into demoing, but I would start at the top, work my way down until I start to feel that the segments are getting more and more mobile. Okay, so don't worry about the joint play aspect of treatment yet because we haven't gone into it, right? So if you can, I'm going to get you guys to, what we're going to do is we're going to partner up. We are going to do one trade of treatment. We're going to go for a break after that trade of treatment, and then you're going to come back and we're going to finish off with the second treatment, where you, if you were therapist, you are now body, and then body is now therapist and you. All right, so what you're going to practice is, you're going to practice your consent for treatment. You are going to do some face down treatment just so you can work on the upper portion of the back and shoulders, because I know your classmate probably really needs it. And then you're going to turn them facing upwards. You're going to work on the neck, around the head, around the upper shoulders, and see if you can actually start to feel where things are restricted. You aren't going to encounter anybody in this class that has any instability, unfortunately, but you will encounter restriction in your classmates' necks. So deal with the restriction and then just do what you can to apply some of the protocols associated with instability. Activate the muscles a little bit, see if you can assess and just move around the individual vertebrae to see how it feels. Okay, we haven't done the joint play yet, so just tinker with it, see what you're feeling, see how the tissues are interacting with you. Okay, any questions before we get started?